Hello, my name is Elliot Sloane, and I'm pleased to have the opportunity to speak with you today about Global Clinical Engineering Day and share my thoughts about where this field is going. And I'm going to do it through the lens of my own work as a clinical engineer and tell you a bit about the fusion of clinical engineering and information technologies, which is happening in our field just as with almost every other field of engineering, science, and business. My bio is a background. I am a HIMSS and ACCE fellow, and I have been traveling on what I describe as a road less traveled, because I've been working in the intersection of health technologies and clinical information systems for many, many decades. I spent 15 years with ECRI Institute, working not only with the testing and evaluation and forensics of medical devices, but also developing all of the information technologies that ECRI Institute uses even today to support ongoing research and patient safety. I then spent 10 years with a for-profit company that was involved with medical device rental, repair, refurbishing, manufacturing, and also pharmaceuticals manufacturing. And since about 2000, I have worked as a professor of business and clinical engineering, health systems engineering, and e-health in several universities, including Villanova University, Drexel University, and South University. And I run a nonprofit research institute known as the Center for Healthcare Information Research and Policy. What I'm sharing with you is something that began as a large national discussion back in 2001, and it was a meeting in which we had two presentations on the convergence of clinical technologies and information technologies. And we had speakers from GE, Agilent, who was a company that emerged from Philips, and that was in 2001 in Baltimore. Also, we talked about departments in hospitals, clinical engineering and IT departments, and we talked about the collaboration that was emerging to allow reliable, safe sharing of medical information and also of networks and data systems. By 2006, we were talking about the concept of really big systems engineering challenges and opportunities in healthcare for clinical engineers. And in this presentation, I pointed out that the National Institute of Medicine in the United States, along with the National Academies of Engineering, published a book about engineering a new health partnership, and in it they describe with great clarity the need to inject systems thinking and engineering perspectives into healthcare in order to improve safety, availability, cost effectiveness of healthcare, not just in the United States, but around the world. By 2008, we were working on even a larger perspective, which is systems of systems engineering. And the difference is that we actually have many systems in hospitals, as in other industries, that are interconnected. The operating room is dependent on patient care and information coming from the emergency department, also from pathology, radiology, and when the patient comes out of an operating room, they have to be discharged into an ICU, step down, home care, etc. And as early as 2008, about 8 years ago, we were talking about what can we learn from the military efforts of Army, Air Force, Navy, joint forces across the world who are collaborating and cooperating together to share information and provide safer, more reliable, more affordable, more sustainable technical infrastructure and platforms. At that point, GE in 2008 became interested as well, and we did presentations talking about this new concept of a clinical systems engineer, really clinical engineers who are taking more and more ownership of the entire clinical technology infrastructure across the healthcare space. And I began to talk about another concept, which is the sentient hospital, a hospital that is itself smart and has capabilities to manage patient safety, in addition to environment, building security, temperature, access controls. I think ultimately we're going to see hospitals that are actually quite a bit more automated, maybe in the same sense that we're looking at a next generation of self-driving cars. Big picture, frankly, but all of these things are clinical engineering activities from my vantage point. This whole concept has been picked up around the world. So I'm going to share a few other areas. For example, in Barbados in 2008, we had all of the English-speaking Caribbean nations together. And in fact, it turned out that they're beginning to see networked clinical technologies, electronic medical records, national systems, uh, systems that are sharing with the Pan American Health Organization and the World Health Organization. Looking at China in Nanjing in 2009, talking about a digital hospital, the fact that tomorrow's hospitals are really not going to be based on the typical separate medical devices and separate information systems, silos of information, but instead they'll be interconnected systems. And my colleagues in China really took to this quickly, translated these slides and presentations to Chinese. Thank you to my colleague Zhang Kun in Hangzhou. And because of that, we have had many future-looking discussions, and I see new technologies and systems emerging in China from that work. In the US, we continue to look at the integration of medical devices and electronic medical record systems, or health information systems, or hospital information systems. And in fact, these capabilities are becoming very, very real today. In the US and around the world, integration of medical devices into the information system is rapidly providing automation of data flow, which improves safety, timeliness of data, and decision support system capabilities. We, in addition, have been talking in other countries in the Middle East, such as Kuwait, Dubai, and Saudi Arabia, about this convergence function because, in fact, in many of these countries, there's little distinction between the clinical engineering and the information technology, or ICT, information and communications technology leadership. In fact, in Saudi Arabia and in China, the two are very, very heavily imprinted and overlapped. In 2013, Tom Judd, Paul Sherman, and Joe Welsh and I presented a presentation about the need for clinical engineers to receive more training. And we presented a number of concepts of approaches and dimensions of knowledge that clinical engineers should be adding to their portfolios and insisting that their biomedical equipment technicians learn. Those include things such as databases and telecommunications and networking, security and privacy, and also, interestingly, decision support systems and strong analytic and data display systems. This is continuing to move forward. In Italy, just this year, in 2016, I had the pleasure of addressing the Italian Clinical Engineering Society, and I talked about the merger of lifecycle control cost analysis, which we've used in the medical technology field, combining that with total cost of ownership concepts, which have emerged out of the business and information technology field. And we had the good fortune of not only a presentation, but a 5-hour tutorial on this where we could share spreadsheets, analytic tools, and discussions about how to plan the next decade of complex systems that provide clinical excellence in healthcare. I've been the co-chair of a group called Integrating the Healthcare Enterprise for about 18 years. I'm now the emeritus co-chair of that organization. And as you see in all of these domains that go back to 1998, all in red are all the devices that are involved in those. And all of those individual silos or areas of healthcare never looked at integration of their data across those silos. But in fact, the patient in the center needs all of that data. The physician in the center needs all of that data in a timely, accurate, complete way. And now we are in a position in this decade ahead to really provide integrated and automated data collection. We have even extended to the home and the personal health record with a group called the Personal Connected Health Alliance, PCHA, using their Continua guidelines. We can extend data acquisition and monitoring to home care patients, patients in nursing homes, and other less acute settings. So we're moving towards the area of mobile and wearable technologies. And the latest version of that, which we'll be working on in 2017, is devices on Fire, which is fast health information retrieval, which is another interface that will allow more mobility, more flexibility, and better adaptability to smartphones and apps. Because precision medicine is unfolding, we're trying to provide healthcare directed to the point and time of care specific to the person. And so all of the standards that are down on the bottom of this slide shows all the different technical areas that are woven together by IHE and by Continua in order to provide the step-by-step connections between the personal, the hospital, and ultimately the regional or population health systems. It is a lot of work, and I have to admit that sometimes I reflect like the Greeks of old. Heraclius of Ephesus said, "Nothing stays the same except change itself." Well, really what he said is you can't really dip your foot in the same river twice, because the second time the river has flowed past. If you think about all of your clinical engineering activities and look in the mirror, you'll know that you and we have really pushed the envelope ever since we began this field, and those of you who are entering now are looking down the road further and intend to push the envelope further. So I say with some joy and a little bit of tongue-in-cheek, be careful what you wish for, because you do have to be relentless in pursuing it. So all of these areas and more, we're adding mobile devices, proteomics, genomics, a very personalized record keeping and clinical, we call them advanced directives, so that people can actually help participate in their destiny and their healthcare into their 100-year and 105 and 110-year aging. And then, of course, all of this, we have to connect all of the people, because it isn't really about technologies. It's about society. It's about patients. It's about the entire healthcare environment in which we all exist. The technologies are simply underlying infrastructure to enable improvement of healthcare for your parents, your family, your kids, your communities, your nations. We're working more on books in this area. I'm an author of a joint publication of clinical engineering from devices to systems, and in my chapter, I've tried to begin to put together more interesting information and often open source information that you can get free online from online sources. So you might want to look at this book to see if it helps you grow your activities, your career, your departments, and your programs into this converging space. Yes, there are some warnings. We have to be vigilant about the total cost of ownership, because really the purchase price is only a fractional part of the cost of ownership. Some say it's only 1/10 or 1/20th of the actual life cycle cost or total cost of ownership. It might even be less. So you have to purchase wisely. You have to purchase with a vision of what you really need and appropriate technologies for your environment, for your economy, for your healthcare goals, etc. This is, in healthcare, we're seeing the largest, most rapid industrial transformation ever to happen. We're seeing all of this happen in just about a decade, maybe 2 decades. Another decade from now, much of this will be history. Much of these books will be written. Much of these accomplishments will be things we'll be talking about. I look at activities in e-health in South Africa and in Saudi Arabia and in Latin America and in Europe, and everywhere there is uptake, there is innovation. China is leading in this area, and we've really never seen this kind of change this quickly. We have to be aware that culture will eat strategy for breakfast, lunch, and dinner, or in other words, people like to do things the way they have always done them. It's very hard to change hospitals. It's very hard to change medical doctors, very hard to change nurses, and frankly, very hard to change us clinical engineers. Change doesn't come easy, doesn't come quickly. You have to allow for change while still being persistent and visionary in the work that you do and your research and your investment of time. You have to manage risk. Sometimes I do feel like this young lady sitting out on the cliff trying to hold myself up one handful at a time. Fortunately, my life is rarely at risk, but in fact, there are many, many, many risks with information technologies, network, cloud computing, apps, and none of them are known or defined. So we are really approaching some exciting new frontiers in this field. And we also have to manage this Gordian knot, this conundrum of managing quality while still expanding quantity. There is a way to do this. We've done this in every field. Automation is part of our ability to do this. In e-business, e-commerce, we have concepts of mass customization, and we're working in that in the healthcare field as well. In many ways, personalized medicine, precision medicine, is talking about both balancing quality and quantity instead of wasting the wrong treatments for the wrong people, trying to give the right treatments for the right people at the right time. Your role is to mine all of the available resources. Well, there are so many resources online, and I forgot to even list WHO and PAHO, which have tremendous resources, books, and guides available for free. The National Institute of Medicine in the U.S. We have to engage in continuous lifelong learning. We've got to focus more on our own clinical engineering skills and things like human factors, home care, mobile wearable devices, all sorts of information technologies, including data analytics, data visualization, human system interaction, and more. Product conformity testing and certification. We need more reliable, durable products that we can trust and know how to purchase. Our own professional credentialing, just as with airline pilots and so many other specialists in so many fields, we have to continue to develop our ability to understand and represent our skills correctly in the marketplace. And then so much systems and systems of systems engineering has to be kind of recalibrated, rethought, and reapplied to the 21st century healthcare challenges. I hope that you will join me in supporting and encouraging your peers, your subordinates, your supervisors, and understanding that there is an emerging and ongoing fusion of clinical engineering and information technology, and join me in helping develop training and educational courses and books and seminars for this important field. I want to thank you for allowing me to join you today on this celebration of Global Clinical Engineering Day, and thank all of you for your hard work, your inspirational work around the world to improve healthcare, not only in your own communities, but for everyone else, for my family, for your family. Thank you. Look forward to celebrating with you again next year and talking about new innovations in this field.